for providing us such a wonderful opportunity of learning. Today, neurointerventional surgery case-based discussion. Our faculty is Dr. Sukalyan Purokayastha. He is head neurointervention and endovascular surgery Institute of Neuroscience, Kolkata. He is a very good friend of us. Whenever we need any help, he is always there to help us. We had some of our younger colleagues who had their fellowship training under his supervision. So he's always helping us in all aspects. Basically, Dr. Sukalyan Purokayastha had his MBBS from Assam Medical College. Then he did his MD from the same institute. After that, he did DNB from New Delhi and DM Neuroradiology from Sri Chitra Medical Institute, Trivandrum. He has completed also this is clinical training in radiology from UK. He has also many training from various institutes all over the world in Turkey, in Thailand. So he is doing excellent job in this field. He is one of the leading neurointerventionists in India. So for the next today's presentation, basically case-based discussion on dural fistula. This is one of the difficult subject for those who are practicing neurointervention. I hope we all will learn from Sukalyan, and we are waiting for this. So over to you, Dr. Sukalyan.
Thank you, Dr.
Yeah.
Good evening to all of you. Thank you, Dr. Shafiq, for this nice introduction. Yeah, and thank you, Medtronic, also for this wonderful session, for hosting this session. Yeah, so today, let's start with dural fistula, and I'll start my screen sharing. Yeah, is it okay? Can you see that?
Yeah, it's okay.
It's okay. Right, so let's start. So initially what I thought is probably I will discuss one or two cases, and then when Divyansh has sent the timing, I saw it from 7 to 9. So I got a bit worried that what will I do for 2 hours with 2 cases. So hurriedly I picked a few more cases from the collection and put few cases. So let's discuss that. So may not be these are too complex cases, or let's start with some simple basic facts of DAVF, because this is what I feel is a bit complicated. Anatomy is a bit complicated, and the understanding of the dural fistula is also important. And but the good thing about the DAVF is this is one of the lesions of the brain which can be totally cured with neurointervention, because arteriovenous malformation of the brain, that is what I'm talking about, the pile malformations of the brain, sometimes are very difficult to treat, and the risk is also high. But in DAVF treatment, endovascular treatment, I feel the risk of treatment is substantially low as compared to the AV malformation of brain, and we can do a great job in treating DAVF in endovascular way. So I'll first discuss one or two couple of slides because maybe few of my friends are junior and they will just brushing for them. And so the incidence is not really known because this is a rare disease. This is not a very common disease like cerebral aneurysms or AV malformations, but this is maybe around 5 to 7% of the whole arteriovenous malformations of the brain, if we see. It is a bit more in females, and it's virtually unknown in children. And obviously, the male also constitute a large sum. So the incidence, male-female incidence, is not that the difference is not that high, but maybe it's a bit more common in females. Now, if we want to know the etiology is also, it's not very clear to us. Okay, so here we have written around 10 to 15%, but many literature says that it may be quite low in incidence. But sometimes 5 to 10 should be a good estimation. Now, we know that the dural sinus are the main outflow sinuses of the brain, and they take away all the deoxygenated blood to the heart from the brain, and these sinuses are the main outflow tracts. So if there is some sort of thrombus formation in the sinuses, what really happens that, first of all, in the first instance after the localized thrombosis, the brain takes an alternate route. So if it's one of the sinuses gets affected, the brain drains to the opposite sinus. But there are a lot of variations in the transverse sinus or in the sigmoid sinus, especially, where most of the dural venous, arteriovenous malformations are situated, and we encounter. And what are the sort of the congenital malformations or congenital variations of the dural sinuses? That one sinus may be a bit stenotic, there can be septation in the sinus, there can be two channels, there can be some bony stenosis, which we can see some sort of stenosis which are very difficult to dilate. So these are some of the malformations or some of the variations which predisposes a sinus thrombosis when the person is influenced by maybe some sort of dehydration or prothrombotic status. Okay, so the dural sinus thrombosis, initially what happens, so once the part of the dural sinus gets thrombosed, the natural tendency of the brain is that it tries to re-establish the flow. So how it re-establishes, it sends some of the arterial supply, which is in the dural leads, and try to, make some way to the sinus, and that usually results in the dural arteriovenous fistula. But
Hello. Audio is not coming, yeah? Hello.
Yeah, we are not able to hear Dr. Sukalyan.
Yes.
We'll have to call him to check.
Okay, let me call him. Yeah.
Yes, so now we can see you and hear you. Please unmute Dr. Sukalyan.
Okay. Probably there was
the slide. Yes, sir.
Some connection issues.
Yes, sir. You can again share the slide.
Okay. Okay. Am I audible?
Yes, sir, you're audible now.
Okay, thank you. So
Yes, sir. Yeah.
yeah,
But we can't see your presentation.
You can't see my
No.
presentation. Okay.
Yes, now we can see your presentation, sir.
Yeah.
Thank you.
If there is any more problem, then maybe I'll switch over to some other connection. Okay.
Yes.
Okay.
Thank you.
Okay. So trauma is what I have said. The trauma probably it causes some sort of a localized fistula, dural fistula, that is direct communication from the dural artery to the bile vein. And infection sometimes is again a cause for the dural fistula. Usually it happens after sinusitis, otitis media, and usually those sort of vascular malformations usually we see in the region of transverse and sigmoid sinus. So how do they present? The dural fistula, usually they present because of, depends on the venous drainage. So where there is venous hyperpressure because of the connection between the artery and the vein, those sort of vein will dilate, and it usually will hamper the drainage of the normal structure which they were draining. So usually we see symptoms depending on that particular area. So if it, like as for example, like if it drains into the ophthalmic vein, it can give rise to ocular symptoms. If it there is the reflux into the sinus, and the reflux, the pressure of reflux is quite high, then the blood might reflux into all the sinuses, both the superficial and the deep system. And there can be increased features of increased intracranial pressure because of the generalized hyperpressure. And because of raised ICT, there can be a visual loss, and the patient can present with decreased mentation. And of course, they can have seizures. And that happens because of venous hyperpressure, generalized venous hyperpressure. Now, in case of a high-grade malformations of the dural AVM, what happens? Usually, there is direct communication between the dural artery and the cortical veins. And when there is direct communication, in that case, there is localized area of the vein which gets where the pressure becomes very high, and they can rupture, causing bleeding. It can have seizures and can have neurological deficit depending on the area of involvement. And of course, the commonest feature is headache because it affects dura. So we know that dura is a pain-sensitive structure, so it can give rise to headache. And of course, the commonest feature is tinnitus when it involves the transverse and the sigmoid sinus. Now, it is usually considered to be a benign lesion until unless it really drains into the cortical veins, and there is real venous hyperpressure into the whole system, which can give rise to very early obtundation and seizure, decreased mentation, and death if it is not treated very early. I'll show you one of a couple of cases in that. Now, how do we classify? So there are various classifications, okay? But the commonest one and the easiest one is the Borden's classification, which is type 1, type 2, and type 3. Type 1 lesion, now we are mainly concentrating here, the Borden's classifications. Say there are dural arteries. Now, where from these dural arteries can arise? It can arise from the external carotid system. It can arise from the internal carotid artery. So all these arteries have got the dural supply, and for the junior colleagues, that you have to study the blood supply of. Am I audible? Hello.
Yeah,
Yes,
sure.
sir, you're audible. Yes.
Okay, thank you. I thought my internet is giving problem. So you may study the blood supply of the dura, which will give you an idea that which other arteries can supply in a particular location. So when a dural artery supplies directly into the sinus or the leptomeningeal veins, so we call it a type 1 fistula. And it drains antegradely into the system. Okay, into the sinus involved, and there is no occlusion of the sinus. And so that's what is type 1 means. Type 2 is it directly drains into the sinus, but because of the very high pressure in the sinus, affected sinus, there is retrograde flow into the opposite sinus. That maybe in case this one transverse sinus is affected, it can drain into the opposite transverse sinus, or it can go into the deeper systems like straight sinus or into the superior sagittal sinus. And type 3 is when there is direct connection between the dural artery, it may be from the external, internal, or vertebral, and it connects to the subarachnoid veins. So we call it type 3. Now, keeping this in mind, if we see the Gingian and Merlin classification, they have a bit elaborated out of it, but basically it is more or less same. As you can see it here, that is the type 1 drainage into the sinus with anterograde flow that we've already discussed. Type 2, they have elaborated it a bit more. It drains into the sinus with reflux into the sinus only, which is a bit benignish. If it drains the cortical vein, which gives rise to symptom early, and if its pressure is too high, it can give rise to both sinus and the cortical vein. Okay, so when we deal with type 2B and 2C, these are the lesions which can give rise to the clinical symptoms very early. Usually type 1 lesions we do not treat unless the tinnitus and headache is too bothering. Otherwise, it's not much of a problem. Now, type 3, when it drains directly into the cortical vein, which is one of the problematic areas, and it can give rise to intracranial bleed and seizure quite early. And type 4 is basically, essentially, it's a type 3 lesion, but the draining veins are quite ectatic. Okay, and type 5 are the lesions which also drain into the perimedullary veins of the spinal cord. It can be a posterior fossa, dural AV fistula, which can drain into the posterior fossa veins, and in addition to that, it can drain into the perimedullary veins of the sinus. So that makes it type 5. And usually the patient presents with venous hyperpressure and myelopathy features in those cases. Now, if you see the sites involved, that can be in the superior sagittal sinus, it can be in the cavernous sinus, sigmoid and transverse sinus. They are quite common areas. Cavernous sinus is also common. Torcula and tentorial DAVFs are also quite easily seen. Anterocranial fossa DAVFs are a bit less in frequency. But out of all this, the anterocranial fossa DAVF, sometimes they are very difficult to treat in an endovascular route because of the approach may not be that straightforward. Now, this one, if we can come into the classification by Jack Morin, he has given and classified it in a totally different manner. Okay, and what his classification, although it looks quite simple, but this is the pathological classification. These are the anatomical classifications, and this is the pathological classification. One is the osteodural, dural, and duroarachnoid. What is osteodural? Osteodural means when these external carotid arteries, like the occipital artery, the superficial temporal artery, usually they are outside the cranial vault. Okay, so they are outside the cranial vault. The middle meningeal artery is inside the cranial vault. So, and they are totally different the way they supply the dural fistula, because when an occipital artery is involved, it has to go inside the skull through the foraminus. Okay, so usually those sort of classifications we call it osteodural. Dural is basically mainly the dural arteries. Arteries are supplies mainly the dural arteries and drains into the dural sinus or the dural dural veins, veins. And what is duroarachnoid? That means it again further involves the more inner structure, and there can be pile recruitment in that, or the artery can directly drain into the pile supply. Okay, So I hope the classification and it's a bit clear to all of you. And so this is a schematic diagram of Borden's classification. As you can see here, this is the type 1. The artery drains in the fistula, which forms from the dural artery and in the wall of the dural sinus, and the red blood, what is shown is the arterial blood, which mixes with the vein and it drains antegrally. Because the pressure is quite low into the downward system, it drains antegrally. So what does that really mean? It means that the sinus, which is involved by the dural fistula, is patent and there is no stenosis. Okay, so that's why the downgrade, the antegrade flow is still there. So if there is stenosis happens at this area, so with this small kind of supply, the blood has to find its way in a retrograde fashion. So it's it will go into the opposite transverse sinus or superior sagittal sinus, and if the pressure goes further high, it can drain into the deeper system, into the straight sinus. So that's how it works. So here what they have shown is that the type 1, where the blood is draining antegrally, here they have shown that the sinus is not patent. It may be thrombosed, or it may have very fibrotic stenosis here into the downward sinus. So that's how type 1 and type 2 works. So type 2A, B, and C, that again depends on the mixture of the sinus and the cortical veins, how they are involved. The type C of Borden classification, here what you can see that the dural artery is coming and directly joining with the pile veins. Okay, so this is a very high-grade fistula where the pile veins are directly involved. So if the size of the pile veins remains normal, it is type 3. If it is dilated, the veins are ectatic, it further upgrades the classification of the fistula. So here the lesion, what we call, is the duroarachnoid lesions. Okay. Now, what are the risks? So type 1 and type 2, usually there is no risk. So if the sinus is nicely patent, usually we don't treat, or if you want to treat, you can just go ahead and block the arterial feeders, or if the patient can have some sort of compression of the arteries, manual compression, and that usually works well. Now, if it is type 2B or type 2AB, the risk is increased. So maybe around 10 to 20% risk of bleed in these things. Type 3 and type 4 the risk is quite high. So early treatment is very important. And why it should be treated? Because of the symptoms, headache, ICP, raised ICP. So when there is raised ICP, the mentation will change. There can be visual loss, papilledema, and if it goes further high, there can be rupture of the veins and it can cause bleed. Now, I have already told about the manual compression and transarterial embolization. We used to do particle embolization quite early, maybe 15, 20 years back, but I don't think the PVA particles are of any usage nowadays when we treat the dural fistula, because invariably they will break up and they are not permanent. Glue we use, NBCA, but transvenous embolizations with coils, and now this is quite an old slide, so now it is replaced by Onyx, and Onyx has completely transformed the endovascular treatment of dural fistula. That everyone has to admit, because after the introduction of Onyx in the market, when we used to treat this dural fistula probably 6 hours, 7 hours, even 1 or 2 cases I remember in my initial days in Sri Chitra, we treated for 16 hours, 18 hours, Go to each and every arterial feeder and embolize with glue, which is difficult. See, the problem or the pathology of the dural arteriovenous fistula is in the vein. not in the artery. So if you want to treat the artery, the answer will always be no, because you can't treat the whole fistula through if you treat the artery only, if you block the artery. So the malformation or the fistula is in the wall of the uh, sinus. So you have to treat the sinus, or you have to treat the vein. If there's a direct connection between the artery and the vein, so you have to treat the vein. Of course, you will treat the artery, but the most important is that you treat the foot of the vein, or the vein which appears first. Okay, so that is the point we have to remember. So when we see a dural fistula, the good thing about it that if there are hundreds of arterial supply, it converges to one venous sac. Okay, in most of the cases, until unless it is multifocal, which is very rare. So it happens in one particular venous sac, which may be stenosed, which may be flowing, or which may be totally On anticoagulation because you are treating the cortical veins. So if the one of the why we do embolization, because there may be thrombus progression into the cortical vein, and the normal drainage area can get blocked. The patient can present with bleed, seizure, which you can aggravate if you do not give anticoagulation. So anticoagulation is a must, at least for 1 month. What I do is I keep injectable, something like Fragmin or Clexan for 3 days, and then overlap it with NOACs like Eliquis, 5 milligram twice daily, Apixaban, and then just keep it for 1 month, and it settles the issue. So this is post, and obviously you have to keep the patient on anti-epileptics.
Well, can you take few questions now before moving to
yeah,
take
please.
That would be better, yeah.
Yeah, please, because I'm just going from the higher grades, yes.
Yeah.
Please.
So there is few general questions from your overview talk.
Yes.
If it is grade 1, what is your follow-up protocol in case of grade 1?
Yes. So grade 1, first that you have to nicely see the patient. See the patient means you have to work out the patient with an MR scan. CT, I don't like MR scan, and along with the DSA. So these are the two things which is a must. So in DSA, you see that what are the arteries involved, and if there is any propensity to shift to the higher grade or not. What is the propensity? What are the arteries involved? Okay. So if the ascending pharyngeal artery is involved, the middle meningeal arteries are involved, and if there is venous stenosis, and some sort of the venous duplication or some sort of opposite side stenosis, opposite side hypoplasia, all these things are there. They have a higher chance of going into the higher grade. And of course, you should also see the procoagulant activity of the patients, okay? Like protein C, protein S, all sorts of things. You're a neurologist and you know better than me. So all these things you should see. Now, you do not need to redo the angiogram quite fast. You need to check your patients because the patient will come to you only probably with mild tinnitus or with mild localized headache. So what you do is you tell them to go for compression exercise. They should compress the right side with the left hand, left side with the right hand, and the common carotid artery. The common carotid arteries, because you need to compress both the external and internal. So if you compress only the internal carotid artery, it will not cause much good. So you have to do it a bit below the common carotid artery. So the compression exercise should be done. And you should check your patients every 3 months. If he or she says there is increase in the tinnitus, you should go do a redo check angiogram. And if you think that the fistula is progressing, or if her headache and tinnitus is too disturbing, you can go ahead and treat that.
So what is your personal experience? Does it regress? Do you have any data like that?
Yeah, we have a couple of cases where the fistula, there is spontaneous thrombosis of the fistula. And if you see the literature also, there is quite a high chance that the fistula can spontaneously thrombose in case of a grade 1 fistula with compression alone. So, but if it increases, then you have to treat. But most of the patients, I would say most of the patients, until and unless it's a cavernous sinus location, because in those cases the patient will present with some sort of chemosis, they will come to you in grade 2. They usually they don't come in grade 1, but if it's in grade 1, you can follow them up.
And next question, I think you already answered. In case of if we have to take ascending pharyngeal, we have to go to meningeal lungs as distally as possible.
As distally as possible.
I have a question in that regard, and one of my residents also.
Yeah.
Do you prefer balloon microcatheter in this case?
Yeah, yes. So I will come into that. So I think I have used a couple of cases, but I could not get it because whatever cases my technician has given, I just put that. Now, balloon, that is scepter. Okay.
Mhm.
Scepter, I used a couple of cases in occipital fistula because the scepter, you can't take it to the middle meningeal artery. One, it is not advisable to take into the ascending pharyngeal artery because ascending pharyngeal is a very tiny vessel and you will invariably you will rupture the vessel. But that I was discussing in another forum, so they told that they have taken it. But now Scepter Mini is coming, which is something like catheter, microcatheter through which you coil. So probably with Scepter Mini you can take. But in case of an occipital artery or temporal artery, superficial temporal artery, you can take Scepter Mini or Scepter and embolize that. So which is definitely a good option. But I will tell you how I deal in my cases. I don't like to use balloon, but how do I do? What we do is just pressure cooker technique. So which is something like a balloon. Yeah.
There is two questions. Type 3.
Yeah.
Can you call it AVM rather than fistula?
AVM type 3 means which type 3? What do you mean by type 3? That one means the person who has asked me the question. Then I'll answer.
I think it is from Dr. Shumon Rana.
Okay, fine. So AVM, by definition, we mean pile AVM. Okay. So pile AVM or pile AV fistula. Now, sometimes if the AVM is superficially located, okay, I've not put examples here, but if I talk someday on AVM, I can show that. If there is too much of arterial shunt in the AVM, there is sort of a sump effect. Okay, sump effect, what you call it, and they draw blood. So when some lesion draws blood into the lesion, the surrounding area becomes a bit hypoxic, and they try to develop some new vessels, and the new vessels can develop from the dura itself. And there is a secondary dural recruitment into the pile malformations, but we do not call them AVM. We call it AVM with a dural recruitment. Okay, so type 3 is something like dural fistula, dural artery, which is going into the pile vein. So there is a direct connection between the artery and the vein. There is no nidus involved here. And it is not inside the brain parenchyma. It is outside the brain parenchyma. It is in the wall of the dura. So we don't call it AVM, we call it AVM.
Okay. So one more question. In case of incomplete treatment, is there any possibility to proceed from grade lower grade to higher grade?
Yes, I will show you one case. How do we do that? But there is a possibility. You should try to occlude the fistula completely. Otherwise, what can happen is you have to try and get some alternative route. How you treat that, or try to reduce it as much as possible, but there is a chance that it can go into the high-grade fistula again. Yes.
Yeah, thank you. I think you can proceed to your next case. Thank you.
Okay, so foramen magnum. So foramen magnum, it is an area where it is again a bit difficult to treat, and usually we see a very high-grade fistula in this, like type 4, type 5 fistula, or type 3B sort of fistula. Now, this is his young guy, who is a very jolly young guy. I remember his name, I think. Yeah. And he came with bilateral lower limb weakness. Now, if you can see this, you can see that there is a bit of hyperintensity in the cord, into the cervicodorsal region, and there are a lot of tiny flow voids, which is going quite down here. So obviously, what is the first differential diagnosis? It is some sort of a spinal arteriovenous fistula, because this guy was probably 27 here. But sorry. Yeah, I can see here it's 27 only. So at this age, we do not see spinal dural fistula. So obviously, it has to be spinal perimedullary fistula. So obviously, we did a spinal angiogram. The complete, it was normal. So when we did the cerebral angiogram, you can see that the vertebral artery, there is a large foramen magnum area region fistula, and there is venous congestion mainly into the foramen magnum area and going down into the spinal perimedullary veins. So nicely seen here. At the time of treatment, the fistula, we kept a balloon here because this is the area which, I'm so sorry, this is in the torcular region. There is a mistake. Foramen magnum, I'll come the next case. This is the torcular region. Yeah, next case is foramen magnum. So you can see that there is a large shunt here. So if it is the torcular region, you have to save the torcular. How you save the torcular? We put a balloon here. So now, previously we used to put coronary balloons because you need large diameter balloon in this. But nowadays, Bolt makes quite large balloons, semi-compliant balloons, and you can do that. But these are pretty costly. So keep it now. You can see that although this is occipital artery, but this is quite a straightforward artery here, and you see check all the vessels: occipital artery, medial meningeal artery, and out of this was the only nice supply, and this is the area of the fistula. So you can see that there is direct venous drainage into the foramen magnum region and going down into the spinal perimedullary veins, and those flavoids, what we saw into the spinal cord, were these perimedullary veins. Now, this is the onyx cast, nice onyx cast through this vessel, and all the veins. This is the dural vein of the posterior fossa, and as you can see that it has gone up to the proximal, the foot of the proximal part of the vein. So once it traverses the foot of the vein, you can think that your treatment is complete. Now this is the onyx cast. Some of the occipital artery is filled here, which is okay. AP and the lateral view, and this is the angiogram, and this is the follow-up angiogram. You hardly see any flavoids, and the signal abnormality in the cord has completely gone, and the patient also improved quite significantly. Cavernous sinus. You know, the cavernous sinus dural fistula is something like a CC fistula. Okay, but depending on the type of cavernous fistula, we classify whether it's a dural fistula, direct dural fistula. That means type B, C, D, all can be the variations of the dural fistula. Okay, because the dural branches of ICA into the cavernous sinus is type B, dural branches of ECA is type C, and dural branches of both ICA and ECA to the cavernous sinus is type D. So, if you are not dealing with a direct cavernous sinus fistula, you are dealing with dural fistula of the cavernous sinus region. Sorry. Now again, the CC fistula depends on the venous drainage, as I discussed earlier. It's not different, and like this, the patient comes with to you. Now, the patient will typically say that it has happened over quite a long time. Okay, it has happened over quite a long time, and usually he does not present with any tinnitus. He can't see any abnormal flow inside his head. Can't hear. So obviously, again, you have to check. So what we see that there is a very tiny fistula here from the middle meningeal maybe, or from the superficial temporal artery. And mostly these are supplied by the dural branches of the ICA. So why it is draining anteriorly? Because the posterior drainage of the cavernous sinus is blocked. Now, this is the angiogram. You can see that there is a very slow flowing fistula from the external carotid system as well, and it is going into the both superficial and superior and the inferior ophthalmic veins and supplying the fistula. So obviously, if your cavernous sinus, inferior petrosal sinus is blocked, either you have to go from the anterior aspect, or if you try, you can definitely dig into the inferior petrosal vein and make a route. And what we do in these cases, usually we try with transcend wires, okay, from the striker. Transcend wires, now it is sold by the Boston Scientific Peripheral Division. And that transcend stiff wires are quite good for making this route into the inferior petrosal sinus. Usually Traxxas do not do that because it is quite soft. So you can do that and go into the foot of the ophthalmic veins. This is the superior ophthalmic foot, inferior ophthalmic, and the sac of the cavernous sinus you have to block, and the patient will be cured. And this is what we see after the treatment. So now, superficial superior sinus. Superior sinus is area which is sometimes maybe a bit difficult to treat, like intracranial fossa, because mainly they are supplied by superficial temporal arteries, and they are so tortuous that it is very difficult to reach through that area. And this is why I kept this. It has gotten very atypical venous drainage, and the patient presented with a sissy fistula-like feature here. Okay, his right eye was quite swollen, and this is the fistula. Now, if you see that, this is the external carotid artery, this is the superficial temporal artery, which is going and supplying. There are some from the middle meningeal as well here, superficial temporal. Now, if you see the venous drainage, it is traversing all the way, and it is coming and draining in the region of the superior ophthalmic vein. Okay, so that's how the patient presented with that. So we took the middle meningeal route and blocked the fistula here. Okay, again, onyx 18. And this is how it looks like after the completion of the fistula. And this is post-op. Once you treat the patient, once the fistula's area, the artery, and the foot of the vein occludes, it's a cure. Superior sagittal sinus DAVF, one more. So these are sometimes difficult lesion to treat, because many cases you won't find a direct route into the system, and there is so much large area of the superior sagittal sinus may be involved. And what you need to study is whether the normal brain is taking superior sagittal sinus or not. If the normal brain is not taking the superior sagittal sinus, you are happy, you can go ahead and block the fistula either through the transarterial route, or you can, if your distal part of the transverse sinus is open, which is in most of the cases it is not, because fistula mainly develops because of distal transverse sinus narrowing or thrombosis. And then in that case, either you take the transarterial route or make a bar hole here. So my neurosurgery colleagues were quite helpful to do that. And you can go ahead and fill the sac with a combination of onyx or glue and coils. Okay. So if you are using glue in this sort of cases, don't use glue less than 60% of concentration. That is very important, and you can cure the fistula. Condylar DAVF. Condylar DAVF is again a very difficult area. So where exactly it happens? It is in the condyles of the occipital bone, and usually they are type 4, type 5 DAVF. Now, this is one of the very young guy who is the son of a doctor, and he had a gradual onset of difficulty in swallowing, difficulty in speaking, and difficulty to walk. And this is the MR he came in with. So obviously you can see that there's a large flavoid in this area. So obviously you know that you are dealing with some sort of a fistula in this area because this is completely extraxial, compressing the medulla quite badly with edema, and that's why he is And this is the CT scan he had done in another hospital. And this is the DSA. Now you can see that it has been, you know that how it gets supplied. It usually gets supplied with the occipital artery, the ascending pharyngeal artery, the dural branches of the vertebral artery, and these patients can have perimedullary venous drainage, like in this case, large venous sac which is dilated and ectatic, and bilateral supply from because this is if it may be unilateral, in this case probably this is the right-sided one, but it can get supplied from both sides. Usually the branches of the ICA do not supply because they do not reach that area. Your middle meningeal artery will not supply in this sort of lesions. The ascending pharyngeal artery can supply, and in fact that is the largest branch sometimes which can give rise to the condyle DAVF, and because that part of the dura usually gets supplied, and the occipital artery. So there's a large fistula here, large venous sac, and as you can see here, AP lateral, the vertebral artery, AP lateral, huge big venous sinus. Okay, so again, this is the ascending pharyngeal artery. Now you can see that this is the anterior branch which goes to the pharynx. This is the posterior branch which goes and directly supplies this large sac. So this area is the microfistulae, and this is the vein which appears first. So what we have to do is we have to block this area only, and that's a cure. So again, this area, what we do is because this is a very large artery, and keeping marathon here or any detachable microcatheter, probably I used here Apollo here, because I need some area for reflux, and I can't keep any catheter here, certainly for sure, if marathon gets blocked. So although my choice is marathon, here I used a detachable microcatheter. Here one point why I use marathon here, because taking the detachable tip microcatheter through this small tortuous, I'll show one of my video. The middle meningeal artery is quite difficult because the area of attachment is a bit bulbous, and that is the area which gets stuck into the tortuosity of the middle meningeal artery. So I like marathon in that situation, and marathon and Traxxas combination works wonderfully well. So this is the ascending pharyngeal artery, and this is the largest straightforward branch here as compared to the vertebral artery feeders or the occipital feeders here. And you see all the areas. This is the first venous sac which arises. So you can be certainly sure that this is the first, this is the area which you have to treat. Now, there are two catheters. One is detachable and probably another coiling catheter, which we took. And this is the area. This is quite distally placed area. How you know that in the AVM also, in the pile AVM also, how you know that you are in the proper position? When the vein directly fills. So you need not be worried that I'm too distal. If you are not inside the venous sac, you are never distal. So in the pile AVM malformation also, when you are inside the nidus, how do you know inside the nidus? Because inside the nidus, there are many microfistulae. So when you inject, the vein will fill directly. So that is the area where you start your embolization. Okay, so you are quite distal into the malformation, and put few coils proximally beyond the proximal detachable and put some glue. And so I don't use balloon. I tend to use more of what's called the pressure cooker technique. And once you are there, then you can be certainly sure. So here's few of the coils and some high concentration glue inside, and then you block the whole fistula, and it is gone. So so these are the post images. So I kept it, the angiogram, which will be interesting for you to see. So you can see that how the fistula drains here, the perimedullary venous drainage, the first sac, the whole of the posterior fossa is congested, the vertebrae. So here the things to be noted is that all his venous systems are patent. Okay, so this is a direct fistula from the dural artery to a pile vein, which is the condylar vein in this case, which has got a direct connection with other pile veins of the posterior fossa. And so that's why there is so much of posterior fossa venous congestion here, what we can see. So now this is supply from both the sides, so it looks quite pretty bad. So this is the ascending pharyngeal artery, which is a straightforward vessel. So we took this vessel. So there are some medial meningeal recruitment here. I will not tell this as a feeder. This is called recruitment because of the sump effect. So once you identify all your anatomy, to study all the anatomy, how the brain drains here. That is very important. You can see that the brain is draining still antegrade. Okay, so in this case, the posterior fossa is involved here. This is the occipital artery, distal. So you have to go distally like this and give a selective injection. Okay, and then only you can identify the fistula, or you can study the fistula. So you have to, again, because these can be quite tortuous, but still you have to take all this tortuosity, take it quite distally, and then start your embolization. You can start your embolization. No need to put coils before starting your embolization. Once you see that your onyx is refluxing in that particular time, you can put coils and do your pressure cooker, and then again start embolizing. I will go maybe a bit fast here. So coils here, some glue. So I use usually in these cases I use headway duo because this is a bit smaller catheter, and you can put glue and coils through headway duo. And so once you block that with onyx, you immediately get a cure like this. See this whole chunk of this big whole chunk of venous sac, which is the collector vein for the dural fistula, is blocked with onyx. And once it is blocked, the fistula is cured instantaneously. So, but in this case, you have to start your anticoagulation right from your treatment itself, and keep the anticoagulation at least for a month. Because as you can see, the fistula is cured here, and not be worried again. So this fistula will never come back again, because you have killed the vein, which is the offending structure. So this is the occipital artery. That we can see the stasis in the occipital artery and the normal filling of all these scalp feeders. So this is the post. So now you have to explain to the patient that just after the embolization, maybe for the first couple of days, the patient can deteriorate, and you have to keep additionally these patients with some steroid, and at least for 3 weeks, and then the patient will improve. Because immediately what we're doing is we're blocking the whole thing with a solid thrombus. So obviously the compression will increase and he will deteriorate, but eventually he will he will improve. So this is the post. Now, what he was asking, I think somebody was asking regarding this dural AVM and dural AVF, but this is again an atypical case, very atypical. Hardly we see this sort of cases, AVM and AVF, which is which is there, but in 2 different locations, having one venous, sharing the venous drainage. So this is the vertebral artery, which is that. You can see the fistula here into the right transverse sinus. The distal transverse sinus on the right side is blocked. So that's why there is retrograde flow into the transverse sinus on the opposite side, into the superior sagittal system, and probably some congestion. Now here, what you see that there is a fistula from the internal carotid artery, which is mainly draining through the superficial middle cerebral vein and the ophthalmic veins. And the patient came with the features of CC fistula. Okay, you can see that there's a whole lot of congestion into the. So when we studied, I found that okay, fine. This is the middle cerebral filling of the fistula, and you can see that there is extracranial and the ophthalmic venous drainage. So obviously the patient, and this is the dural fistula. Now, in the later part of the dural fistula, again, because of venous hyperpressure, the same vein was filling. Okay? Now, this high flow, tiny AVM and large AVF. So this is my detachable microcatheter, I think Apollo's, I don't know what is the length, and then started injecting onyx here. Can you hear me? Hello?
Yes, sir, we can hear you.
Okay, thank you. So this is onyx. So gradually you wait and try to form a nice cast of onyx and then go forward. And once it started percolating, you should finish it. You should not wait. So, and you can heat also onyx sometimes to increase its permeability. And sometimes I also use squid in combination with onyx. First you try form a plug with onyx 18 and then continue with squid 12. But if you heat onyx, it percolates very nicely. So this is a complete occlusion of the arterial system. And you can see that that vein which is there, which comes very slowly into the last part. But this part of the malformation has completely gone. There is no filling, further filling, and there is no filling of the vein. The pile vein, which was eventually draining with the middle cerebral system, the cavernous system, and it was draining into the, now this is the lateral view. You can see that it is not there. The initial stage, the vein is not coming. Please see that. In the later stage, because of the venous hyperpressure, because of the fistula, the vein is still filling. It is in the later stage. So immediately I understood that despite completely curing your AVM, the patient may not be cured of his symptom, because he came to me with the symptoms of cystic fistula, with the redness of his eyes and some headache. So, and also there was some fear in my mind that you exactly do not know where this vein, see this, the foot of the vein is going. So once the foot of the vein starts, you stop. So exactly where that vein is, if any normal vein is coming here or not, you can't be 100% sure. So obviously I put the patient on some NT coagulant, although it was a bit low. It was, I think, 2,500 of fragmin. The patient next day morning became restless, and this is what we have now. Now, why this has happened? This has happened definitely because of some sort of a venous occlusion. Okay, so this is a typical bleed. What we see that this hemisphere is a bit more congested, and there is some bleed in the parenchyma. Okay, but the patient did not have much deficit. He was extremely restless, so we had to again intubate, give him mannitol, keep the anticoagulation. The fistula again, the posterior fistula, because if you do not block the posterior fistula, you will not be cured. Now, I just kept it for the beginner, just to make you understand that how you negotiate, sorry, or may not be this one, how you negotiate. So this is, so we have gone a bit of tortuosity into the middle meningeal artery, went there, then blocked. I will just, for the want of time, I will go a bit faster. This is not very different. So we blocked the thing, and he became okay after some time, but he had a turbulent course. So it is same like the previous case that we blocked it. Now, transverse sinus type 4 fistula, high-grade fistula. For some teaching reasons, see, now not all the fistula of this transverse sinus will have like this. Usually in the transverse sinus, we see type 2C, type 2. Now, this was the feeder, again for the beginners, extreme tortuosity of the middle meningeal artery. Now, and that is the only route which is draining. Now, somebody was asking that whether we can call it an AVM. No, certainly not. This is a dural fistula directly into the vein with tortuosity and ectasia of the vein. So we obviously define it as a type 4 fistula. Now, these are the, now you can see that how the dural branches of the vertebral artery is crossing into the opposite side and draining the fistula. But the point to be noted here is the site of fistula is 1. Okay, so if you deal with that particular area of the vein, now here you see that this is a combination of, now my I think this is neuron through neuron max, or probably this is cat5. You can take Nevian or any other catheter which goes a bit distally for a stable. So this is again marathon and Traxas combination. Sometimes it is very difficult to negotiate these arteries, but you have to be patient. Try to make a very tight J, because sometimes this J works like this. You have to try negotiating, and it will take you with the J. It is, and it will not perforate the dura. Otherwise, if you push too much, the dura can get perforated, and you will be losing all your access here. So now I just fast forward it. You try to take. Here I tried maybe for another half an hour. It was very difficult to take it. Once I was pushing it, it was going like this. Then what I thought is, okay, I'll go and take this route. This is a bit straightforward and going distally, and from here the fistula is arising. This is the first vein which appears. Now you can see that it's going a bit posteriorly, sorry, forward because of. So now I took it into that one. So I'm more or less near the fistula. Sorry, the onyx injection. So when onyx is percolating, you should not wait. Now, taking these detachable micro catheters may be a bit difficult, and the marathon goes very well in this. So take another roadmap, continue injection, don't stop here, because once it is percolating, you should not stop. When you stop, if you see that your onyx is going into an abnormal vein where you do not want, or into an abnormal artery which you do not want, stop there for 2-3 minutes. And then start injecting. Don't stop for too long in this, okay? When it is not going forward, now you can see that the whole of the vein, so you may not feel the vein this much, you may stop, and then you just take the catheter out, and once you do that, it is cured, and you can see that the whole of the fistula is, whole of the sinus is patent here. Now there is a bit of stasis into the vein, because this vein is also draining some normal structures. There is no fistula, so anticoagulate the patient, and you get a cure. See this? The whole of this, the left-sided fistula and everything got cured. Yeah, any questions? Somebody's asking me any question?
Yeah, we have questions. We'll ask after you finish your
Okay,
presentation.
fine. So it is gone. Yeah. So now probably I was talking about this case, foramen magnum type 5 recurrent fistula. Now somebody asked me that can it recur? Yes, it can. Now this is one of the horrible looking fistula. I treated her probably 5 years back. 5 years back, and that time she had fistula with this sort of large veins. That time we blocked the fistula completely. What I thought completely. She was from Bhutan, and I told her to come back after 3 months to do a check angiogram. She didn't turn up. 6 months back, I went to Bhutan. She came to meet me, and she was doing perfectly well. So, and then I told her, okay, just come back we'll do a check angiogram and see. But she was, oh, doctor, I'm doing fine. I don't have any issues. And then I think 2 months back, she had a bleed in the posterior fossa, and again she came back. So now, I do not know whether that time I left any feeder. Probably yes. And this time, again, she came up with a huge, big fistula into the region of the foramen magnum, as you can see here. It was supplied by bilateral occipital, bilateral middle meningeal, bilateral ascending pharyngeal, bilateral branches from the ICA, branches from I think few of the branches are posterior auricular because that was probably recruitment. So, again the usual root here, the middle meningeal. So now you can see that the forward penetration of onyx is less and it is coming back. Okay. Now here probably I used a detachable tip microcatheter because the artery was quite straightforward in this case. So you stop here. You can stop here maybe 10 minutes or even 12, 15 minutes. Initially I used to stop not more than 5 minutes because it is in the onyx, it is written that you should not wait more than 2 to 3 minutes. So then I discussed few cases. You can see that how big the sac is. The onyx, despite so slow injection, the onyx was breaking down and going and settling. So this is a bit scary. And if it is so, then you wait for some time. But what I did is because it was percolating, I continued my injection because I knew that it is going and settling in the sac, which has got some sort of a stenosis there. So once you do that, the distal part of the vein is getting blocked. You should not wait. You should go fast because otherwise what can happen, it can have a proximal venous hyperpressure more into the cerebral system and it can be sometimes catastrophic. So you inject, you continue injecting. Here is the injection. So, and you should tell your assistant that he should be prepared with onyx because sometimes even 1 or 2 minutes of delay in the injection, the forward percolation of onyx may not be that good. So you should not wait once it is going forward. So you can see that the whole crevices of the system is filling. So now I have kept only one plane. You have to juggle with forward if you do not have a biplane, both AP and the lateral view. So these are the branches of the occipital arteries which are filling. The whole of the sac is gone. Now again you do all the branches selectively. So the middle meningeal, ascending pharyngeal artery, anterior and the posterior branch, no filling of the fistula, normal filling. Now what I took is that probably a twig of the ascending pharyngeal was filling. So again I went distal and a few of the crevices. Here I injected a little bit more onyx here because this time I didn't want her to come back again to me. So Again, you can see that some of the onyx is going into the crevices, and you have to switch between AP and lateral just to check that it is not going to the feeders of the feeders of the vertebral artery, because the vertebral artery dural branches are quite near in this, and so sometimes you can see that this is the vertebral artery dural branches, so you can see that that is which is outside the fistula, and the brain is draining quite nicely and antegrade. So, and this is the vertebral artery AP, and you can see that the forward flow is established here. Some of the venous congestion which will remain for some time, which will go gradually. So initially also she had a fourth ventricular bleed, as you can see that she was shunted because of hydrocephalus after the first this is the shunt after the first 5-6 years back. She was shunted and she was doing perfectly well. So the teaching point is that you should be extremely careful before telling that the fistula is cured. You should have a selective injections of all the feeders nicely, and then only you should stop your treatment. I think we can stop here. What's the time? Oh, it's going to be 9 o'clock actually. So,
Thank you,
so I'll
Sukalyan.
conclude here. So it is curative, endovascular embolization, but you have to make your strategy depending on the route and type. Total embolization is a must for cure, and obviously you need a DSA follow-up at least once after 3 months after your treatment. Thank you. So,
Thank you for your
questions?
brilliant presentation.
Thank
So
you.
can I give the floor to Dr. Suman Rana for his case presentation?
What is-
Then we will come to question and answer. Is that okay? Can we give Dr. Suman Rana
Yeah.
for his case
Yeah,
presentation?
Himani.
Yeah, so, sir, Dr. Sukalyan, you have to exit from the presentation, and then another presenter will be able to share the screen.
You will share his case.
I'm just doing that.
Sure. Thank you, sir.
So we'll come back again for question and answer sessions.
Yeah.
Thank you.
Thank you.
Yeah.
Yeah, Sean, Mr.
Yeah,
Please,
yes,
Assistant
sir.
Professor of Dhaka Medical College. Go ahead. We are working together.
Yes. Thank you very much, sir, for a very elaborative and very excellent presentation for us. It was really very good for us. It's a lot of learning points are there. And I want to present a case recently we have done. 88 months old boy with progressive macrocranium since birth, with failure to weight gain and a bit irritable. And on examination, his head size was large with OFC 49, which is more for his age. And there was sutural diastasis, and all the frontanelles were pulsed, tense, and open. And on general examination, the baby was a bit malnourished, otherwise is okay. Neurologically, otherwise the baby was intact. And systemic examination, nothing was found, with a very good cardiac status. So our provisional diagnosis was hydrocephalus. There was occipital bruit there also, occipital bruit on auscultation. So our diagnosis was any sorts of intracranial vascular lesion, that could be vein of Galen, with features of raised ICP. We have done the CT scan, non-contrast CT scan showing there is a big, well circumscribed isodense lesion at the back of the head, with compression over the posterior part of the third ventricle, possibly which causes triventriculomegaly with periventricular hypodensity. And on contrast CT, we can see it's a brilliant contrast enhancing well circumscribed lesion there, with a lot of venous structures in the subarachnoid space and fissure, possibly showing the features of venous hypertension there. On MRI, the lesion is mixed intensity, both in T1 and T2, and there is inhomogeneous contrast enhancement. And we can see in T2 weighted image with a hole there, like a hurricane. Possibly it indicates some vascular lesion there. We have planned for digital substruction angiography on that baby. On the right side, it's selective external carotid artery injection showing there is a big venous lacunae there, supplied mainly by the branches of the middle meningeal artery, and also by the different meningeal artery with occipital artery also. On the left side, non-selective injection on the common carotid artery showing there is no supply from the internal carotid artery, but supply is from the branches of the external carotid artery, mainly the middle meningeal artery and the occipital artery. So this is the run. Possibly it is not going to be played. And on the right side and the left side, DSO was there, run was there, but I couldn't play here. And our brilliant resident, Dr. Musan Ashfaq, has tried to animate this. There is a big venous lacunae in the posterior, venous lake in the posterior aspect of the head, with both antegrade and retrograde flow supplied bilaterally from the branches of the external carotid artery, middle meningeal artery, and occipital artery. And our clinical radiological diagnosis was this could be a torcular dural sinus malformation with arteriovenous fistula. Our plan is to onyx embolization of that particular arteriovenous fistula. Definitely staged. He was a very 8-month-old baby, so we have planned to do from the right side first, then from the left side, from the transarterial route, of course, to the transfemoral route. This is our planning, how we plan to embolize this dural sinus malformation with arteriovenous fistula. On the right side, we can see the middle meningeal artery with distal branches, how it is supplying the venous leg, sinus malformation at the torcular region. So on the right side, the microcatheter will put as distal as possible at the fistula's point there. And this is the microcatheter we can see here. Then we will put our liquid embolic agent. And as per our plan, we have we put our guiding catheter at the stump of the external carotid artery on the right side. Then we have taken the microcatheter, Apollo, possibly 5 centimeter, over the 0.008 Chikai wire at the fistula's point. And then we started injecting Onyx 18. And slowly, we have able to embolize the fistula's points there. And in the lower pictures, you can see the onyx cast here with the feeding pedicles. But at the end of the procedure, the first time, we have taken shoot from the left side, and that reveals there is a residual shunting arteriovenous fistula there with the residual part of the dural sinus malformation on the left side that is being supplied by the occipital artery and the branches of the middle meningeal artery. So we stopped there for the first session. We just planned for the second session after 28 days later. 28 days later, we have planned for the second session. We have taken our guide catheter in the stump of the left carotid artery and chosen the middle meningeal artery first and embolized as much as possible. Then we just finished our embolization through the middle meningeal artery as the reflux was significant. So we return back and then we go through the occipital artery. This is the transosseous artery. osteodural branches. Then we take in the occipital artery and slowly we inject the onyx and fill almost all of the fistula's point. But irony is that at the end of the embolization, our stock has been finished. There was no onyx, so a tiny part of the fistula we can see on the right side on the top. The tiny part of the fistula is still left there. So we kept the baby like that, and we can see the onyx cast, left side, right side, and that is being shown in animation. Right-sided onyx cast with the feeding pedicle, and the left-sided onyx cast with the regurgitated onyx material in the feeding artery pedicle. And we can see the preoperative CT scan, contrast CT, with a big leg of venous leg, dural sinus malformation, and after first embolization, 1 month follow-up, we can see there is size as a whole, the size become decreased. We can see the cerebral mantle in front of the sinus, dural sinus malformation that is being visible right now. And after second session, 2 months after follow-up, you can see significant reduction of the sinus malformation with a reduction in the compression over the surrounding brain tissue and reduction in the hydrocephalus also. Just we can see is the comparison between the pre-embolization and the post-embolization contrast CT. We can see there is no periventricular lucency, the reduction of the hydrocephalus, of course, though there is a ventriculomegaly there. There is a reduction in the venous hypertension because we cannot see any venous structures in the subrectal space and fissure in the second CT. And the sulci and gyri become visible on the post-embolization CT because the rest ICP has gone. And we can see the follow-up in the pre-embolization angiogram. We can see on the right side, on the left side, and post-embolization angiography, we can clearly see the sinus malformation and AV fistula. And this is a preoperative image of the baby, and postoperative, the baby gained weight and he become very jolly there, and head size also decreased. So this is the scan sent by her mother just a few months back. The baby is doing very good right now. Thank you very much. My question is, what can we do with the residual fistula there? Should we go ahead or follow it up?
Yeah, thank you, Dr. Shravan, for your nice talk. Yeah, so far we remember onyx was percolating very nicely, but all of a sudden we got out of stock of onyx. So, thank you. I thank Dr. Sukalyan from the bottom of our heart. It was a wonderful session. We enjoyed some extraordinary cases that you did. We want to dream to do such kind of cases in Bangladesh. So there are a few questions from our side. Can I ask you to disable Dr. Shravan on a screen? Can I ask? Hello?
Yes, sir.
Yeah. Dr. Sukalyan there?
Yes. I want to congratulate Dr. Suman for this excellent, wonderful case. Beautifully done. And I think Divyang should keep more onyx there. He should not run out of stock in between. Yeah, but this is a wonderful case actually, and beautifully done. And maybe, that question you asked regarding should we go ahead and do embolize. The dural sinus malformation, it is something like a vein of Galen malformation, but it happens because of usually it happens during the later stages of the growth of the brain. Because of the malformation of the torque, mainly the jugular bulb. So if the jugular bulb, it usually gets completed by 2 years. If it doesn't happen, then there can be some back pressure into the sinus and it can get dilated. So what you have done is absolutely right. You should do it in stages. It should not be done in one single stage. That is very important. Why is? Because there will be high incidence of this large sinus which can get thrombosed. So it should be done in stages, and onyx is a good thing to, and it is because it is in the wall of the dural sinus. So that's why you should be a bit careful that it is not going into the lumen of the sinus, because the lumen of the sinus is patent. So your injection and all these things should be quite slow so that it does not go into the lumen of the sinus, because you can't put such a huge balloon and protect the sinus. So that is a problem here. So one is that it should be done in multiple stages and slow embolization. So if something is left behind, you can go ahead and treat the lesion later. But what you can do is this sort of tiny residua can get thrombosed on its own sometimes. So maybe if the child head size is decreasing, which you have shown, the brain is coming towards normal, and so just clinically follow this patient up and maybe one radiology. And if the child becomes, maybe when he becomes around 2 years, then you can do MNC and embolize. But excellent case. Thank you so much for sharing the case.
Thank you, sir. Sir, hello, sir. Can I ask you a question, sir?
Absolutely.
Sir, you have told that you are not going to use any detachable catheter and also the tiny wire like Mirage or hybrid wires. Can you explain why you are not using that?
Hybrid sometimes I use, 007 sometimes I use, but if it is too tortuous or very sharp bend, and the artery is very tiny, sometimes the U loop of Traxus does not negotiate. Then we sometimes use 007. But the problem with those wires is they do not get much support. So that is one problem. So support is less. So most of the cases you can get away with Traxus. It is cheaper, and hybrids are quite costly. So, and it has got a good support also. But sometimes if it doesn't work, sometimes you can take this thing, Synchro. Synchro is another good wire, or the new wire from the Medtronic, Evigo. Evigo is also something like Evigo. Yeah, it is something like Synchro. So you can do that. Regarding the detachable tip catheter, if you are using detachable tip catheter and if the patient can afford, you can definitely use. But sometimes in very tortuous anatomy, the detachable tip catheter doesn't seem to go as easily as marathon because of the junctional area. It's little bulbous, so that area sometimes can get affected. It can get injured if you try to negotiate quite hard in a highly tortuous anatomy. But if it's a straightforward anatomy, I think it's a good choice to take detachable tip microcatheter.
Yeah, thank you, Dr. Sukalyan, for your nice and brilliant presentations on some of the difficult cases. There are some questions from the residents and doctors. One question is, do you know why the dural fistula is more close to the lateral sinuses? This question from them.
Yeah. So these are the areas where we see more of the variations. So like one side is hypoplastic, and then there is a stenosis into the transverse sigmoid junction. or there may be the jugular bulb, which is not less formed. Yeah. So that's why, there is less variation in the superior sagittal sinus as we see the transverse sinuses. And there are more dural supply into the area of the tentorium, the petrous region, and the base of the skull. So probably this is one of the reasons, but I really do not know the exact answer.
I have a question regarding balloon. You told it is in the torcula, you have to save the torcula, so you prefer using balloon. Yeah, and one of your cases, you showed the long segment superior sagittal sinus fistulas.
Yes.
How do you assess whether the patency of sinus is important or indispensable or not? What are the criteria you are going to occlude the sinus, and what are the criteria you are going to keep the sinus patent?
Yeah. So that is like when this sort of patient presents, they present with venous hyperpressure, raised ICT. So what you need to check both the internal carotid arteries and the vertebral arteries till the most delayed venous phase. That is very important. And you see that how the brain is draining. If the brain do not take the route of these major sinuses, then it is safe to sacrifice the sinus. But there are some reports, definitely there are some reports that you put a balloon there. So it is a long balloon there into the superior sagittal sinus or the transverse sinus. Inflate the balloon and then inject around the balloon, because the fistula is in the wall. And initially there were a couple of reports that stenting of the sinus. They put a stent which gives sort of an outward pressure into the wall of the sinuses, and then you put a balloon and then inject. So the fistula is in the wall of the sinus. So if the brain is not taking, because the brain has already established another route, which is a transcortical route or some other route, and it is not taking that particular sinus, it can be sacrificed. But if a natural route, if it is not sacrificed, it's always better. So if you see that it is draining and it is patent, then it's better to put a long balloon and then inject onyx around the balloon.
Thank you. And one of our residents wants to know regarding etiology of condylar fistula.
Etiology, I think all the dural fistula is more or less same, and probably some sort of venous thrombosis or trauma. Probably these are the etiological factors. But as you know, that the exact etiology of DAVF is mostly unknown.
Since majority of the audience are the surgeons, so one of the questions from them: if any patient presents to you with bleed, for instance, dural sinus usually, frontal dural sinus usually presents with bleed. So how do you treat them?
See, if the bleed is so like in case of bleed anywhere inside the brain, if it is mass producing, compression producing, it has to be evacuated. There's no doubt about it.
Yeah. I think Brigadier Jahir Bhai wants to make some comment. Please, Jahir.
Hello, Dr. Sukalyan. We have met in 2018 in our Dhaka Medical College Hospital. There was a seminar, probably I forget. So that this session has become overwhelming for us. You have shared such nice cases with us. We are really benefited. One small question to you regarding the cavernous fistula in type 1. So from your experience, what do you suggest to use, whether one should use, foil or onyx or foil or onyx in case of type 1 carotid cavernous fistula? Can you hear me?
Yes, okay. I think he got disconnected.
Can you hear me?
Yeah.
Yes, sir, we can hear you.
Could you
Yeah,
Could
we
you
can hear you. I can
Please.
see you.
Please.
Yes. Can I ask again? Did you follow me?
Yeah, please. Yeah, please.
Okay, that was very nice session that I wanted to say first. And second thing, in case of type 1 cavernous fistula, from your experience, what do you suggest? One should use coil or onyx, or case to case it should vary?
Case to case it will vary, but cavernous sinus fistula, usually it is dealt best by transvenous route. So if your petrosal sinus is patent, it's best to go through the petrosal sinus, or sometimes there is nothing but to go through the facial vein route or through the superior ophthalmic vein route. So first is coil, definitely. And then inside the coil mass, you can inject onyx. It is very safe. It reduces the number of usage of coils, and it is safe. It is safe. It usually does not cause any extra cranial nerve palsy.
Okay,
Yeah.
thank you. And although
you.
these second, third, fourth, these are the little bit uncommon. So I think in case of second, third, or fourth type, one can use onyx.
Right. So, Dr. Sukalyan, hello. I think connection.
I think again, yeah, sir. There's some
Yeah.
issue.
Divyan, hello. Next time we have to address this issue.
Sir, actually, there is a lot of bad weather in Calcutta, and I think there's some issue at Dr. Sukalyan.
I think we will conclude in 1 or 2 minutes. Just waiting for Sukalyan to come. Yeah.
I'm just calling him, sir. I'm just calling him. Yeah.
We are just on the verge of conclusion.
Waiting 1 minute.
Hello. Yeah.
Yeah. Sorry.
So I think we are close to conclusion. It was a wonderful session. More than 100 participants were there.
Thank you.
Is
I think
Dr.
some
Farooq?
last question was there. I could not answer that question.
Javir bhai, can you repeat
Oh,
that?
yes. I was asking regarding cavernous fistula. The second, third, and fourth type, these are a little bit uncommon. So in that case, I think one can use onyx.
You can use, but onyx in the cavernous fistula, using only onyx probably is not very advisable. You can just mix with coils. That's better.
Thank you.
Yeah.
I think you will love to meet two of your fellows from
Yes.
those who are with you.
Yeah.
Is Dr. Farooq here? Please, would you want to say hello to Dr. Sukalyan? Dr. Farooq, are you there? Dr. Farooq
Yes, sir is there. Sir is there.
and Dr. Irshad, are you there? You can say hello to Sukalyan. Yeah, I see Farooq here.
Yeah, Dr. Farooq is there.
Both of them were here. Anyway. So, for conclusion,
Any more questions, sir? Any more questions?
anybody having
you want to address?
questions, you can directly ask him. Anybody having any questions, you can ask him directly from the audience.
I have a question regarding, sir, pathogenesis of the neurosurgery fistula. Like any trauma, surgery, or in case of DST, there is chance of developing a neurosurgery fistula. But not all the patients develop such. So is there any particular factors with an individual who has sustained a trauma or VST or in surgery that can lead to dual arteriovenous fistula?
After what we see that after sinus thrombosis, after surgery, it is rare. After trauma and surgery, it is rare. It's not that common. So trauma is understandable. There can be dural fistula. The artery can tear because in all the dural channels, there is an artery and there is a vein. It is not only the artery. So the artery can get connected with the vein because of the trauma. After surgery, there can be a venous thrombosis, and it can give rise to the fistula. But these sort of etiology are rare. And that much we know that. But what happens is, obviously it varies from person to person. The person has some sort of angioproliferative stimulus which can give rise to the dural fistula for some reason or other. I do not know any genetic preponderance is there for developing the dural fistula or not. But the exact etiology is probably most likely is some sort of a pathology into the dural sinus, into the venous wall, which give rise to most likely it's a sort of an inflammatory pathology which happens, and then it forms rise to angiogenetic factors, and which forms the dural fistula. That's what is postulated.
Sir, can I ask one more question, sir?
Yes, sir, absolutely.
Sir, if an individual presents with ICH.
ICH, yeah?
Yes, sir. We have done the investigation and also the gold standard angiography, DSA. And then what should be the time period depending on the type and the clinical situation of that individual to go for the intervention?
Well, see, if a patient is presenting with an ICH, that means you are dealing with type 2 B, C, or type 3 fistula, type 4 fistula. So there is no time to wait. You have to embolize. You have to embolize it without. It's like something like an aneurysm, because it can because obviously there is some venous hyperpressure. So, and on the top of that, the patient has bled. So there is no point waiting. You should treat them then and there. And if the amount of hematoma is big, then obviously you have to evacuate that.
Thank you, sir. Thank you, sir.
Thank you, Dr. Shukar. I think Dr. Farooq is Farooq, you want to say hello to Dr. Sukalyan, please? Right.
Yeah. Hello. Thank you, sir.
Thank you. Thank you. I can't hear you. I can see you.
Okay. Thank you, sir.
Thank you.
He's on the video.
Yeah.
And
maybe this corona problem will go fast and I will meet all of you in person.
Yeah.
Inshallah, sir. Next time, inshallah, sir.
Yeah.
And there is a question from Dr. Hasibul. What are the criteria you choose transarterial or transvenous approach? I think there is the last questions from our side. That is the last question from our side.
Okay. So, it depends actually the type of the fistula. So like the cavernous sinus fistula, it is usually through the venous route, because there is very difficult situation of difficult route to reach the cavernous sinus crevice from the transarterial route. So, and the venous, the anterior cranial fossa dural fistula, sometimes you take the venous route through the facial vein, and you can reach the fistula. Through the facial vein, you can reach the venous cavernous sinus as well. Now, sometimes in the transverse sinus fistula, so if it is a trapped sinus, what I mean is trapped sinus is that, say, the fistula is in the transverse sinus, the distal drainage of the ipsilateral transverse sinus is blocked, and the brain is not taking that transverse sinus, and there is an easy way you can reach the transverse sinus from the opposite transverse sinus. Okay, so you can go from the opposite transverse sinus and block the ipsilateral, the diseased transverse sinus with coil. So you can take a venous route. But sometimes if this part of the sinus is trapped, that means if there is no way you can reach the sinus, then either you can reach transarterially, or you can make a bar hole and make the transvenous route.
Yeah, thank you. So,
Thank you, Dr.
before conclusion, I'd like to thank Dr. Sukalyan for his brilliant talk. We learned a lot, and we are hoping to meet you again and again. And I'd like to
Absolutely.
thank Medtronics also for their beautiful contribution to organize this webinar. And with this, I'd like to hand over this mic to Divyans to conclude the session.
Yeah, thank you, Divyansh, and
yeah.
all the team of Medtronic. Thank you so much.
Yeah, thanks a lot, sir. Thank you so much for your valuable time to spend with us. Because we assure definitely, Dr. Shafiq, that we will continue these kind of interactive and intellectual sessions, and that is our assurance. And thanks a lot to all attendees, also for patient listening, and it is a great and very interactive session, sir. Thanks a lot. Yeah.
Thank you.
On behalf of our entire team. Yeah.
Can I put our hands together for Sukalyan?
Yeah.
Thank you very much.
Thanks, sir. Thanks a lot. Good night to everyone. Yeah. Good night, sir. Good night.
Thank you. Good night.
Thank you.